I will start this webinar now. So everyone, welcome to this evening's webinar, responding to children and adults who have experienced non-fatal strangulation in the context of violence and abuse. My name is Jasmine, your RACGP representative for this evening. We are joined by our presenters, Dr. Eleanor Friedman and Dr. Grace Wong. Our facilitator this evening is Dr. Jane Brabin. Before we get started, I'd like to make acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past, present and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us on. So let's get started. I'd like to introduce you to our presenters for this evening. Dr. Grace Wong is a Senior Staff Specialist Forensic Pediatrician and Head of Department at the Child Protection Unit at the Children's Hospital at Westmead. Dr. Wong is also the Senior Clinical Advisor for the Child Protection at New South Wales Ministry of Health. Dr. Eleanor Friedman is a medical forensic examiner and a sexual health physician with extensive clinical experience in management of adult sexual assault. She is the manager of the Medical and Forensic Portfolio at ECAV, New South Wales Education Centre Against Violence, and is a Senior Clinical Advisor, Adult Sexual Health to New South Wales Health Parvan Branch. Eleanor is passionate about the provision of trauma-informed, patient-centred healthcare. We are also joined by Dr. Jane Brabin, who is our facilitator for this webinar. Dr. Jane Brabin is a general practitioner with a passion for rural regional primary care. She has worked as a medical and forensic examiner in sexual assault services for 13 years as part of the medical team providing a crisis response to victims of sexual violence. She collaborates with the Education Centre Against Violence, assisting with the delivery of education for doctors and nurses responding to victim survivors of violence, abuse and neglect. Welcome everyone. So I'll hand this over to you now, Jane.
Thank you for having me as facilitator tonight, and also a very big thank you to our two experts who will be sharing their wisdom. So our learning objectives tonight, by the end of this online CPD activity, we should be able to discuss the clinical impacts of non-fatal strangulation, identify non-fatal strangulation as a critical event that may not always show obvious injuries, and learn to respond effectively and safely to patients who have experienced non-fatal strangulation. Thank you. Over to you, Dr. Ellie Friedman.
Thank you, Jasmine and Jane, and good evening, everybody. And as I'm sure many of you are aware, we're in the beginning of the 16 days of activism against violence, the 16 days of activism about violence against women. And so this is a really pertinent time to have this webinar because we're talking really about non-fatal strangulation and its role or as a kind of sentinel injury or an important factor in presentations of violence, abuse and neglect. So I'm going to talk briefly about non-fatal strangulation in general and then hand over to Grace, who's going to talk to us about some of the more specific details around strangulation injuries in children. So we know that non-fatal strangulation is actually quite a common occurrence. And if you think about it, the neck is quite an exposed area. So although we know that obviously with all of these general community surveys, it's very hard to tell what actual prevalence is, but it's not an uncommon event to happen to people, and it's not an uncommon reason for people to present following strangulation. But if we look specifically in domestic violence services, then the experience of strangulation as part of domestic violence goes sky high. So we know that in domestic violence, the experience of strangulation is incredibly common, and also in sexual assault services. Obviously, there's a huge overlap between domestic violence and sexual assault, with probably in New South Wales, at least where I work, a quarter to a third of the people presenting to a sexual assault acute service have also experienced or currently experiencing domestic violence. And as we all know, the assailant is often in sexual assault is often a partner or ex-partner, just as in domestic violence. However, if we're talking about non-fatal strangulation, where the patient hopefully makes a fullish recovery, then it might be something that's under-recognized by patients and by healthcare providers, because often we're distracted by the context in which it's occurred in. So if we're thinking about sexual assault or domestic violence, we're often dealing with other injuries or forensic examination following those incidents. And if we don't ask about the strangulation, it may not be disclosed to us. So really, in the time I've been doing this work, which is about 20 years, our awareness of strangulation as a common event in sexual assault and domestic violence has grown and grown. And the more we ask about it, the more we find out. Oh, next slide. Sorry, I meant to be doing my. It's just we had a long conversation before this about who was going to move the slides on, and then I sat there and decided I was doing it. So I think we all talk about strangulation quite glibly, but often we don't really know that we're using a common language, and that's another reason why we may diagnose strangulation, because people may use all sorts of different words. So we can use words like choking, or patients might use words like choking or suffocating, which we might understand as blocking off the airway, but may actually be a form of strangulation as well. So we need to make sure if people talk about something like that, we clarify what actually happened to them. And one of the things that I'm sure you've all heard is that rather than asking, were you strangled, we ask questions like, was any pressure put on your neck? So we're actually asking very specifically what happened rather than what did you call what happened. So we've got an increasing awareness of seriousness. So strangulation in of itself, as well as being quite an exposed area, we've got all sorts of important structures in the neck. And so we're concerned about injury to those structures. And of course, injury resulting, particularly brain injury resulting from anoxia, from damage to the great vessels or the airways. So we're worried about strangulation as an injury. But we also know that strangulation is a marker of seriousness in a domestic violence setting. So we know that people who have been strangled by their partner have a 7.5 times increased risk of future homicide in that relationship. So that doesn't mean by strangulation, it could be by any means. And interestingly, in the UK, the New Strangulation Institute are doing some quite interesting work on the domestic violence death reviews there and the role of strangulation. And people who die through domestic violence are likely to have reported strangulation from not only their current partner, but previous partners. And people who strangle their partners are likely to have strangled other partners before. So it's a bit of a what's the so what of that, but strangulation is common and serious. Next slide. So as I said, it's a potentially fatal act, and it's often either deliberately downplayed because people don't want to go down that path of necessarily a criminal justice path or prosecution path, or it's minimized because people don't see it as a serious injury, especially if they've recovered. It can also be minimized because people forget about it. If you're strangled to the point of loss of consciousness, you can have a loss of memory. So either admitting that you can't really remember what happened or not being able to really remember what happened might well mean that people don't talk about strangulation. So it's quite easy to kill someone through strangulation, but it's also a very good means of control, isn't it? If you think about it, it takes away someone's unable to breathe, they're unable to speak. It's very scary and very controlling. So most people who are strangled will feel justifiably that their life is threatened, that they are in danger of their lives, and that's an incredibly powerful mechanism of control. So there's just a quote here um, comparing non-fatal strangulation to waterboarding. And I think if we think about domestic violence and the coercive control element in domestic violence, that thing of having dominance and authority over the other, creating intense fear, that is the hallmark of coercive control, in which is the environment in which domestic violence happens. So I think if we just understand strangulation as a really good mechanism of power and control, it fits with that domestic violence setting. Next slide. So I've really just put this up to remind us all of what is in your neck. And I have to see if I can talk about this without touching my neck. But the neck is really a very precarious structure. We have got veins, arteries quite close to the surface. We've got the trachea and the airways, the larynx, and they're not particularly brilliantly protected. So the amount of pressure you need to occlude the jugular vein and prevent blood flow, venous blood return is only 4.4 pounds per square inch. So just to give you our and 11 for carotid artery occlusion, which is going to actually cut off blood flow the other way as well, arterial blood flow to the brain. And this is someone said to me when we were talking about this that this was the stat they've always remembered, which was not the purpose of it being there, but it's to open a ring pull a can of Coke, you need 20 pounds per square inch. So it's not very much pressure it has to be, it's not a quick act, but it's not very much pressure and it's not for very long to cause serious damage. So you don't have to be particularly big and strong to strangle someone. Next slide. So what happens during strangulation, as I've alluded to, we've got venous occlusion, we've got arterial occlusion with slightly more pressure, we can have airway occlusion, and that real psychological fear and injury and control going on. Next slide. So often we talk about, we're often asked to assess people post-strangulation. I think that, often, especially in primary care and ED, we're told that someone's been strangled and we're asked to do an assessment. So what should we be asking about? What should we be worried about? Well, first of all, it's really important that if we're taking a history, even if we take a history of the incident, people may not have a good memory of it. We need to ask about symptoms post event. But some people will have no symptoms, will remember no particular symptoms at the time of the strangulation, and 33% will have no symptoms post strangulation. So these are all important symptoms to ask about. Loss of consciousness and urinary incontinence means that someone was close to death. So the time from loss of consciousness to death is pretty short. And if someone's had urinary incontinence, it means they've lost sphincter control, which means they've had serious hypoxia going on. So we know that those are all markers of seriousness, but even with a serious non-fatal strangulation, some people will have no symptoms at all. Next slide. So again, we're going to be asking you to look for any abrasions on the neck, any external signs, and bruising, petechial bruising above the waterline. So and the upper neck and the facial area, bruising on the neck from occlusion. And we're looking the eyes for subconjunctival hemorrhages and for petechiae there as well, looking for soft tissue swelling. And although we know that 50% will have one sign following strangulation, that means that the other 50% may have no signs at all. And we know even from post-mortem studies when people have died from strangulation, there may be no external signs, especially on the neck. So it's very hard to assess just through an examination what is a serious strangulation event. So all strangulation events must be taken potentially seriously. Next slide. So when we're thinking about strangulation, we need to assess the actual strangulation, and we've got good guidelines now. The Emergency Care Institute guidelines for management in ED of patients experiencing strangulation, the PHN health pathways on strangulation, which are out or coming out. So we've got good pathways for assessing strangulation, and those references are either attached to this presentation or can be sent out. But we're also thinking about safety of the person. So if someone tells you they've been strangled in a domestic violence setting, we need to think about their physical safety from the strangulation event, but we also need to think about their safety within that relationship. So it's really important whenever someone discloses violence to us that we're able to have a brief safety planning conversation with them. That safety planning and safety assessment isn't something that's just left up to the experts. And if you feel uncomfortable calling it safety planning or safety assessment, just call it a conversation about safety. And these are some of the questions that we might ask, which will give us an idea of what we need to do to make this patient more safe. Next slide. So if someone has been strangled recently, and we have a lot of debate about what's recency, so we've just been just been trying to understand, but we think that most serious sequelae of strangulation are likely to occur in the first few days after strangulation when swelling is maximal. We do know that there have been incidents of carotid artery dissection weeks and months afterwards, but those are relatively rare. So really we're thinking about someone in the first 48 hours, 96 hours post-strangulation where there might be maximal neck swelling. So if you have any concerns from the history, if they give you a history of loss of consciousness, urinary incontinence, persistent symptoms like headache or isolated neurological symptoms, or they have any of those signs of strangulation, any marks of strangulation, then you probably want to refer them to ED for an assessment. And ED should be able to do a further clinical assessment. And then depending on which bit of the body of the neck they're worried about, choose the appropriate imaging. So that might be CT angiography if we're worried about the great vessels, but sometimes we're actually worried about bony injuries to the cervical spine or neck, or we're worried about the larynx and airways, in which case we might be thinking more about nasendoscopy and an ENT referral. So for acute strangulations, that pathway is very much a clinical assessment. If there are clinical things that make you concerned, a referral for ED for further assessment, imaging, and if necessary, referral. Next slide. So this is a glance of the Emergency Care Institute ACI guideline to management of non-fatal strangulation in ED, and it's so teeny that no one can see it, but it is readily accessible and gives you a very clear list of what things to be watching out for and when to be referring on for imaging. Next slide. So we're going to be referring to ED for recent strangulation, and we'd like people to be reviewed within that 72-hour mark. Because we hope that the swelling, if it's maximal at 48 hours, is going down by then, so we can just look at resolution of any persistent symptoms. I think it's probably a good idea for people to have follow-up again at around 12 weeks, where hopefully all symptoms from a single strangulation incident have been resolved. We can retouch on safety. What this doesn't really talk to is some of our people who have a history of strangulation and trying to work out whether current symptoms are due to a historic strangulation or something else that's happened. And that's quite tricky to work out, but a 12-week assessment to see whether strangulation symptoms have resolved. And then our referral for further management, if any of those symptoms are persistent or signs are persistent, depending on what they are. If we're worried about the great vessels, we may need to speak to a vascular surgeon, but often we want a referral to a neurologist or a neurosurgeon if we're worried about the cervical spine or about neurological symptoms, but also thinking about respiratory medicine and certainly ENT if there's any concerns about the upper airways and the larynx. Next slide. So just to remind you, and of course I can never remember where we're up to, and I'll probably get into big trouble, but the Ministry of Health, New South Wales Parvan branch, have been working with Southwestern Sydney Primary Health Network to develop a series of violence, abuse and neglect focused health pathways, and trying to make sure that these common presentations and issues around violence, abuse and neglect are really accessible and available for all GPs. Next slide. So we've got health. So the adult strangulation pathway. Oh, it's okay. We can go back to the adult strangulation pathway and the child strangulation pathway are live, as are our child and adult sexual abuse. We're reviewing the domestic and family violence. There's a pathway for dealing with perpetrators of domestic and family violence, and we're also reviewing a pathway on physical assault and injury recording, which is kind of, I guess, a skill that underpins all of that. So those health pathways should be available to all of you through the PHNs. Next slide. I think I'm handing over to Grace. Those are the references, and we can share those at the end of the presentation. I'll hand over to you, Grace.
Thank you, Ellie, and thank you for the organisers for inviting me. It's a pleasure to talk to you about some of these clinical issues as relevant to children and young teenagers. Thanks, Jasmine. We can go to the first slide, which is, I'm going to start off with a little bit of a case study. This is an actual clinical case that I dealt with some years ago now, and it was a 9-year-old boy whom I'll call Johnny. He had gone to school, and his teacher, who was quite astute, noticed he had some bruising and swelling and marks to his head and neck, and asked him what had happened. And Johnny said, "It's a secret." And then later on said, "Dad did it." And that led to more conversations between him and the teacher. And he then said to the teacher that Dad had punched him the night before and held him by the throat and kicked him in the leg. He also told the teacher that Dad had told him to tell the school that he got hurt at karate if school had asked. Dad had, in fact, that morning put makeup on his face to try and cover up some of the marks, but it was still visible to the teacher. And the teacher was, of course, very concerned upon hearing this story, made a report to the Child Protection Helpline, absolutely the right thing to do. She then wanted the child to go to emergency, so the school called an ambulance and the child was taken to the emergency for an assessment. So firstly, before we go on with the case, just a little bit on definition. And obviously, Ellie's talked a lot about strangulation, which we know. Thanks, Jasmine. If you can just click, thank you. Pressure applied to the neck. In children, however, not only are we obviously dealing with strangulation injuries in cases of potential physical assault to children, in even younger infants and children, sometimes what we're in fact talking about is obstruction to the upper airway, that is the nose and mouth, resulting in what we would call suffocation injuries. Both of these are actions. And the third, asphyxiation, is a state. And of course, you can be asphyxiated not just from suffocation or strangulation, but in pediatrics, certainly a whole host of other scenarios, such as a foreign body obstruction, drowning, and of course, carbon monoxide poisoning, other types of toxins, for example. Thanks. So then back to our case, Johnny. So Johnny gave us a little bit more information about what happened to him, and he said, in fact, the night before, he didn't want to go to bed. They'd been out all day, they'd been at a trampoline park, he was having lots of fun, and he was mucking around until late. Dad got frustrated with him, he got angry, and he said Dad was raging when he went into Johnny's room while he was lying in bed. Dad hit him, punched him on both sides of the head. Then Dad put his hands on his neck and strangled him, and he was very scared. He screamed. He tried to use his own hands to pry his dad's hands off his neck, and he described to us as feeling dizzy, having difficulty breathing. At that point, his father let go. After that, Johnny said he had a headache, and interestingly, he tells us that the next thing he remembers is waking up in bed the very next morning. So what happened? So when he woke up, his father was in his bed cuddling him. His dad helped him with his breakfast, packed his lunch. He said to Johnny, "Don't tell anyone what happened. Don't tell the school. Tell them something else." He put makeup on Johnny, and he said to tell them about the story about the karate. And in pediatric cases, as very similarly to adult cases, it's important to try and elicit, where possible, a history of what's happened, but particularly a history of symptoms and signs. Obviously, the younger the child is, the more difficult it is to get a history, but in most 9-year-olds, certainly in the case of Johnny, he was quite willing to tell us what happened. Things to look out for: loss of consciousness, confusion, seeing visual changes, headaches, seizures, and Ellie's already talked about loss of bladder and bowel control being a sign of very serious strangulation. So we asked Johnny some further questions, and we said, did you black out or lose consciousness? So that's a pretty hard question to be asking a 9-year-old to think about. He said, I'm not sure. I think I slept all night. We asked him, do you remember anything else that happened after Dad had put his hands on your neck? And he said, I had a bit of a headache, but I really don't remember when Dad got into bed with me. The next thing I knew, I woke up and Dad was there. So we then asked him, sometimes when people are choked or strangled, they can pee themselves without realizing. Do you know if anything like this would have happened to you when you were in the bed? He said, I don't think so. I don't remember the bed being wet. Did you have any changes to your vision? No. Did you have any tingling or numbness in your body when you woke up? No. And have you been having any difficulties with speaking or swallowing? And to that he said, I have a sore throat now, but no other problems. On examination, he had a number of skin injuries, which we will demonstrate. But essentially, the rest of his examination was pretty normal. So he had no difficulties with his airway. He spoke well in full sentences with no stridor. The rest of his ENT examination was normal. We were very careful to look inside the mouth, look for evidence of any subconjunctival hemorrhages. We had a good top-to-toe examination. We did a full neurological examination, and we watched him swallow some water, and he had no difficulty. Some of the injuries, and certainly in terms of a summary of the injuries seen, he had petechial bruising and swelling to the left side of his face and head. He had some bruises to the right ear. He had some linear petechial bruises to the neck on both sides, some bruising to the back of his right shoulder, and some further linear petechial bruises also to the other side of the body, to the left shoulder. And then he had some arm bruises, both right arm and left arm. And these, as you can probably appreciate, even on a 9-year-old boy who's fairly mobile, who would be running around doing normal everyday activities, the overall pattern of these bruises and their location would be highly concerning for non-accidental injury. So Johnny did not require an admission to hospital, but was assessed by the pediatrician. He was clinically well and had no neurological symptoms or signs and no airway difficulties. We did not image him any further. We did consider, given the evidence of bruising on him, whether he needed an MRI or an MRA of the neck. But in the end, given how clinically well he was, we did not proceed with that. And even though we were, of course, concerned about physical abuse in a child of this age who presented with these symptoms and signs, at the age of 9 years, he would be too old for a skeletal survey and bone scan, which we would normally do in much younger children, generally under the age of 2 years, to look for occult bony injuries. So Johnny, DCJ was involved as a result of the helpline report that was made to Child Protection. That's the Department of Communities and Justice. And they came and they safety planned with the family. They put in some supports in the home with Dad, who was clearly having difficulty managing the care of his children. He had a number of stresses in the family. Father was charged by police for assault and found guilty. And we also offered some follow-up for Johnny with his GP in a couple of days' time, and also with his local pediatrician for a few weeks after that. So, in terms of strangulation injuries in children, these are the sort of three main cohorts that we can think about. So teenagers in the context of a sexual assault or domestic and family violence, so injuries by someone, a boyfriend, for example, that's very similar in presentation to your adults. And then we've got a second group of children, like Johnny, who are younger children who may have been assaulted by an adult parent or carer. And then we've got infants and toddlers, and strangulation in this cohort is really quite rare. We do see them on the odd occasion with other non-accidental injuries, but by and large, very, very unusually seen. Again, very similar to adults, significant group of children who have experienced strangulation will have no symptoms and signs, and the other symptoms and signs I won't go through again, as Ellie's already gone through them. Thanks, Jasmine. In particular, in children, one of the things to think about, apart from delayed effects of airway obstruction, which can occur after the first 12, 24 hours, as Ellie has already talked about, is the possibility of behavioral changes as well as ongoing difficulties with memory loss and concentration, which may affect the child's schooling in the medium to longer term. And this is the reason why that we would always recommend that children, even if they don't have any symptoms and signs immediately post, should have follow-up with their GP. There has been a reported in the literature a 13-year-old boy that had a very delayed post-anoxic encephalopathy presentation, but it's just the one case where on day 7, post-strangulation, he presented with some movement disorders, probably due to hypoxia in the basal ganglia. That's just one case, and it's very, very rare. Apart from that, in terms of other neurological symptoms and signs in children, it is believed now in the last several years, based on the literature, that unlike in adults, that strokes due to neck vessel injury specifically is probably relatively uncommon in children in the pediatric population, and that most of the neurological sequelae is related to hypoxic ischemic changes in young children. So in terms of in children, what can we do, same or different to adults? Well, the principles of care are generally the same in terms of how we assess for symptoms and signs. What is different, though, is that children are much less likely to have a vessel injury. We've just mentioned that. And so we generally feel that the need to specifically image the neck vessels is much less crucial than in the adult population. But children do need a developmental approach. Number one, talking to them in an age-appropriate way to try and get the most out of the story that they may have to tell us about what's happened, but also thinking about schooling, as I mentioned before. But of course, additionally, thirdly, is that children require a child protection approach, which is involving generally mandatory reporting to DCJ, thinking through, are they safe to go home or not? Referring generally to emergency for a pediatric child protection assessment. So generally we suggest referring to any closest hospital to you that has a local pediatric service. So it does not need to come to a tertiary children's hospital, but any hospital that has a pediatrician would be fine. Generally, that means that once a report's been made and a child's been referred to emergency, that they will have an investigation generally jointly by DCJ and police, as well as the pediatrician. And of course, we would not generally discharge these children home until we can be sure that they've got a safe place to go. This is a relatively recent paper which essentially demonstrates that in the risk of vascular injury in children who have experienced strangulation is relatively low in comparison to the adults. And generally in severe cases of strangulation in children, the neurological impairment is related to hypoxic injury. Thanks, Jasmine. So it's the question of imaging does become tricky. Certainly at the moment, we would say that the guidelines are not particularly clear, but in a child that's got any neurological symptoms or signs, we would definitely image them. Any child with a story suggestive of very prolonged hypoxia potentially may need imaging, in the form of CT or MRI, but the rest of the children, it will be on a case-by-case basis. Imaging of choice, CT or MRI for evidence of hypoxic brain injury, and an MRA or a CT angiogram, generally reserved for our very unwell patients, or other clinical symptoms or signs that's very suggestive of either airway injury or an air leak. So what should GPs do if you come across a child like Johnny or a teenager who reports strangulation following either a DV or sexual assault type incident? These children should all be sent to ED for a pediatric review because of the need to photo document injuries, for us to undertake a risk assessment for about safety to go home, if home is where they might have had the injury. Tests, as discussed, possibly some very young children may need an eye review, and also for us to be able to arrange for appropriate follow-up, particularly if a child may need to follow up with a pediatrician. Thanks, Jasmine. Okay, so I'm just noting the time, and I want to just very quickly mention this second case that we have, and this relates to the other group of children that I mentioned before, the much younger ones. So this is a 2-month-old baby girl, again, a true story, born term, previously well, and presents to emergency with some fresh blood from the mouth and nose. And mum had found her in the cot like that and had no history of trauma, called an ambulance because she was concerned. There was any trauma that mum was aware of. And interestingly, this same girl had presented just 2 weeks prior to emergency with a history of a bruit or bruit-like event. So a brief, resolved, unexpected event, what we used to call an ALTI. She was found briefly unresponsive and flat again at home. She was observed in ED overnight. There was nothing else found that was worrying, and she was then sent home. Thanks, Jasmine. So this is the baby, and hopefully you can see a couple of unusual findings, one in the eye and one to the tip of her nose. We'll keep going. So what could have happened to this baby? Did she develop cow's milk protein allergy? Maybe someone slapped her across the face. Was it an accidental injury? Could she have been suffocated? Or maybe you can't possibly say. Thanks, Jasmine. So suffocation in infants. Of course, we as a child protection pediatrician are always concerned about cases which may be intentional or abusive suffocation. But of course, suffocation in infancy can also be accidental. And that's a common issue if parents have been co-sleeping, whether it's the overlaying from an adult, or sometimes when babies are put to sleep on top of the adult and both fall asleep and you've got a baby with compromised upper airway due to their positioning. Babies can also be left to sleep in unsafe places, sofas, potter cots, and baby swings. Potter cots are particularly a problem because of a couple of issues. Number one, the risk of head and limb entrapment. And number two, because the mattresses in potter cots are often very soft and very ill-fitting, and that creates a suffocation risk. Baby swings are also problematic, particularly if the baby's not strapped in, and certainly there have been issues from causing suffocation as a result of babies being left in swings. And the risk is increased if a child is very young, born prem, has low birth weight, or already has other coexisting upper airway difficulties. Baby slings, thanks Jasmine, we'll get to the next slide, can also be really tricky if not used properly, and there are certain things which are associated with particular risk. This is a case from a couple of years ago now, a very sad case where a baby, 3-week-old, died as a result of accidental suffocation while being carried in a baby carrier. And so, thank you, Jasmine. So, of course, when we're talking about baby carrying to mums and parents, it's important to remind them of these good principles of how a baby should be carried. And the main thing is that we should be able to see the baby's face and keeping the upper airway open. Thanks, Jasmine. So, having spoken about causes of accidental suffocation, we now turn our minds to the possibility of intentional suffocation and smothering. While this is an less common presentation of child abuse in infancy compared to, say, bruising or fractures or abusive head trauma. It is something that we do see time to time, and in fact, sometimes more frequently than people realize. Mostly this happens to the very, very young infants, usually several months of age or younger. Often it's a carer putting their hand or pillow or bedding on a baby's face, causing occlusion of the upper airway. And it's, as you can imagine, based on the mechanism of how this happens, you may see, as a result of hands, for example, being put on the face, facial injuries from bruising to the face, or from injuries to the lip, or abrasions to the inside of the mouth, or injuries to the frenulum. The other things that sometimes these babies would present with is unexplained oral nasal bleeding. And there's a couple of reasons for that, either because of trauma caused by something applied to the face or mouth or nose, or suffocation in and of itself. The relationship between suffocation and oral nasal bleeding is something that we have known and certainly been talked about in the literature for a couple of decades now at least. But what is not commonly known, even by some pediatricians, is that unexplained oral nasal bleeding is in fact a red flag for potential child abuse when it occurs in the very young child. So we're talking about infants generally with oral nasal bleeding in the absence of any history of trauma or any evidence of an underlying bleeding problem. So that's something to really look out for. But similar to strangulation in adults, even when a child's been intentionally suffocated, they may have no external signs. And so making a diagnosis like this does require a high index of suspicion. Thanks, Jasmine. These photos come from a published paper and demonstrate some of the things that I've been talking about. So this is a 5-month-old baby. You can see some very subtle facial bruises. I can see at least 3 bruises there. They are round, oval, about 1/2 to 1 centimeter in diameter and clustered in a pattern of 3 on the face. And this is highly concerning, highly typical of fingertip bruising caused by pressure, hand applied to the face. This baby was seen in ED and sent home and unfortunately died later with further abuse from abusive head trauma. Thanks, Jasmine. This same paper presents a 6-month-old infant with a torn frenulum. Now, when we talk about torn frenulum, so most people think about the upper frenulum, but this is also a frenulum too. It's the one under the tongue. And we know that this is a healing injury because it's got the white ash scar as it heals. And this baby that presentation is very highly concerning. And we'll go to the next slide. This same infant had previously presented to the hospital with this nasal septum separation, and it was attributed by the carer from some injury from a car seat buckle. But as you can imagine, these two injuries in combination would make you very concerned about the possibility of non-accidental injury. This case is a 4-month-old infant presented with unexplained blood in the mouth. And as you can see, bruising to the tongue and under the tongue, and his skeletal survey showed healing femur fracture, highly concerning for non-accidental injury. This one is a 3-month-old infant, and mum gave a history that the baby pushed the bottle away and went limp. The doctor who examined him was particularly astute and noticed this very subtle but certainly there tongue bruising. And his workup when we did a CT, when they talked about this case during the CT, showed bilateral subdural hemorrhages, and he also had extensive retinal hemorrhages, all of which is very concerning for abusive head trauma. As I mentioned previously, the relationship between asphyxia and unexplained oral nasal bleeding in children has been known for some time. Distinguishing between epistaxis in very young children, whether it's from asphyxia or not, is quite difficult. But certainly in this systematic review, what they were able to demonstrate is that those who had epistaxis and were able to be demonstrated was definitely from asphyxia, also many of them co-presented with altered skin color, respiratory difficulty, patchy changes on the chest X-ray, and some of them had a history of recurrent altes or bruits. Thanks, Jasmine. So when we're talking about unexplained oral nasal bleeding and asphyxiation, generally we're talking about frank blood, not just a little bit of pink serous stuff. In the cases that we come across, it may be just a few droplets, but we've certainly had cases where of proven suffocation where the description and the scene photographs provided to us demonstrate lots of blood all over the onesie, all over the blankets, all over the bedding. And while nasal bleeding is very common in the older child because they pick their noses, they fall over, in young children, particularly those less than 2 years old, and in infancy, extremely rare. And we'll go to the next slide just because of time. And we know that when you've got this unexplained oral nasal bleeding in infancy, something is always seriously wrong. So either you've got a medically serious problem, and I've listed some of those there, or you have a significant child protection problem, as discussed, either inflicted intraoral injury or accidental oral injury, of course, if you've got a good history for it. Otherwise, think about suffocation, either intentional or accidental, as a potential cause. All of these children, thanks, Jasmine, we'll go to the next slide, should be referred to ED and be assessed. Just very quickly mention the other thing that happened to this case that I mentioned. This baby had presented with a bruit just 2 weeks prior. And this is just to remind all of us what bruits are. And while, Jasmine will go to the next slide, thank you. And while there is a long list of differentials, medical diagnoses that we would look for in a child that has a bruit, just to say that not to forget child abuse as a potential differential. And the two, I've listed 4 things there, but the 2 to keep most top of mind, as mentioned today, is intentional suffocation, and the other is abusive head trauma, which can also present with apnea, pallor, changes in respiratory effort, so grunting or not breathing at all, or breathing in an abnormal pattern. All of those things could be a symptom or sign of abusive head trauma. So those are the 2 things to keep top of mind as you think about what could be causing this baby's bruise. Thanks, Jasmine. We might skip to the next slide. So we're now back to our case. So this baby had a couple of things which were really, really worrying to me. Fresh blood from the mouth and nose, as we've talked about now, is a significant red flag. History of bruit, which could have been a medical reason, but again, in the combination with other things, and her physical findings of 1, a subconjunctival hemorrhage of the left eye, and 2, an abrasion to the tip of her nose, altogether is highly concerning. We'll go to the next slide. So the causes of subconjunctival hemorrhage in a young infant, either direct trauma to the eye, which she didn't have. Obviously, birth can cause that too, but she's well outside of that period where you would expect birth-related subconjunctival hemorrhage. This is a new finding. And in combination with this abrasion to the nose, highly concerning for some sort of suffocation injury. Okay, we'll go to the next slide. This is one of the final slides, and I just wanted to let you know about a new resource that's been developed by New South Wales Health. This is a what we call the NAI video. It's a video that's available on the CEC website. Look under the Child Protection tab. You can just Google it. It's a 4-minute animation which talks about symptoms and signs of non-accidental injuries in children, including how you should respond. It is designed for staff working in New South Wales, but some of the earlier parts of the video would be applicable to any clinician working anywhere. Okay, thanks, Jasmine. And now I might hand over back to Jane and Jasmine. Thanks.
Yeah, thank you, Grace. Thank you, Ellie. That was fantastic. Admittedly, a little grim entering the holiday season. It's a timely, a good time to remind ourselves of non-fatal strangulation injuries and suffocation injuries.
There is one question in the chat, and I think, Grace, you've seen that.
Yeah, so the question is, what if the suspected abuser is accompanying the child? Who to call to make sure the child gets to ED? So yes, in a clinical situation with the family, a very awkward and difficult situation, obviously you would explain to the carer that the child needs a medical assessment, that you're sending them to ED. But after that, it would be very important, certainly in the state of New South Wales, to make a report to the Child Protection Helpline to ensure that somebody else other than yourself, but that's the statutory system, is aware that we've got a child with a potential strangulation injury. If the report to DCJ is sufficiently well worded with clear enough indicators to express your concern, most of these children would trigger a response whereby, at a minimum DCJ, but certainly in many cases police as well, will be triggered to undertake an interagency assessment and investigation, looking not just at whether somebody needs to be assessed as being criminally responsible for having assaulted the child, but also DCJ ensuring that there is a safe place for the child to go to. But that's a very excellent question. And of course, ring the ED to let them know that that you're sending the child there. That's another mechanism to ensure that that they've got some way of knowing to expect. And some EDs will also alert a paediatrician to ensure that they're expecting a child abuse type presentation.
Just wondering if anyone else wanted to pop any questions in that Q&A box. I suppose you could also answer that question too, Ellie, in relation to, say, someone presenting into a clinic with the partner that is a suspected person.
Absolutely. And, you know, in the same as with children, that's very common. And also don't forget the people that inflict injuries and abuse also often have huge remorse, and you know they're not just covering up, they genuinely do want their partner, child, whoever, to receive the medical care they need, though they don't necessarily want the full story to be disclosed, as in the case of Johnny that Grace shared with us. So I think that there is a skill in trying to make sure that your patient has the medical care that they need, and that's going to be, has to be our first and foremost. So if that child or that adult needs to go to emergency and the person that's with them, even if you suspect that they have inflicted the injury, if you try and overstep that, you might end up with a situation where that child or adult doesn't get the medical care they need. So whilst I'm not suggesting we're collusive with it, our biggest priority is making sure people get the medical care they need. In the child protection system, we do have a better way of flagging our concerns, but absolutely, if you're sending someone up to ED, say for imaging following a scan, there is absolutely nothing to prevent you, and I would recommend that you call ED social work if they're available, or again, if they're available, a violence, abuse and neglect service to flag your concerns, or just the ED NUM to flag your concerns, because often in that situation, there are places that we can take our patient off to be imaged or to do a urine sample or something, and we can actually find ways to get that person alone. In the case of the adult, they may not want to disclose what really happened or other concerns they have, but we can certainly give them information about health being a safe place for disclosure. If the patient is a regular patient of yours, then you can also have an opportunity to follow up with safety concerns later. So in the case of adults, they might go off to ED and have some imaging done, but you might then see that woman a couple of weeks later for follow-up and maybe discuss the safety concerns then. So there are a lot of similarities and there are a lot of differences. And I'm interested, so someone else has said, should I advise patients that I'm suspecting non-accidental injury? And I don't know. I'm going to hand that back to Grace, because I think it's quite a difficult negotiation sometimes, isn't it? And probably one that relies a little bit on your clinical skills and assessment, not only of the physical injury, but of the social situation you're in.
Yeah, that's exactly right, Ellie. I think if, say, you're in Johnny's case, if mum had presented him and mum was protective and a safe person, then I think it'll be reasonable. Obviously, that's not just a suspicion. We know what Johnny says dad's done. Very reasonable to have a very straight discussion with mum to say that you're mandated to make a mandatory report. That's what you've got to do. In other types of presentations, say you've got a young infant with some facial bruising, or in fact bruising anywhere in an infant less than 4 months of age is highly concerning. Sometimes it's best, even if you suspect child abuse, not to specifically address that in your consultation, because we do need to undertake a proper assessment. We need to rule out bleeding problems. We may need to do other investigations. I would suggest that it would be very reasonable in those cases to explain that we don't normally see bruises in infants at this age. It's an unusual finding. You're worried. You think the baby needs to be medically assessed and may need to have other types of assessments. A pediatrician needs to see your baby. We really need your baby to go to emergency. And generally, once they've been seen in ED and the pediatricians have been contacted and we come and see them, we can then have that further conversation with mum and dad about why we're worried.
That's fantastic. I might close off the session now, if that's okay with everyone. So thank you, everyone. So there is an announcement that we would like to make regarding a new offer by the RACGP and New South Wales Health Partnership. So for an opportunity for you to be able to gain additional measuring outcomes and reviewing performance CPD hours, we'll be providing you with a mini audit and a resource pack in an email to attendees following this webinar. On another note, this is a CPD accredited activity, so please complete the survey that follows the webinar. Once the webinar ends, you'll automatically be directed to complete the survey, and you only need to complete it once. So as again, I would like to extend my many thanks to Grace, Ellie and Jane for presenting, and to everyone who joined